All right, welcome. Today, we're diving into a really critical topic in orthopedics, bacterial infections of bones and joints. Now, this is one of those areas where getting it right is absolutely crucial. A misstep here can have devastating consequences, but a sharp diagnosis, well, you could save a limb, maybe even a life.
So here's how we're going to break this down. We'll kick things off with the clinical challenge you'll face. Then, we'll get into the nitty-gritty of osteomyelitis, that's the bone infection, and septic arthritis, the joint infection. After that, we'll put them side by side to really compare the diagnostic paths. And finally, we'll wrap up with the core treatment strategies you absolutely need to know.
Okay, let's start with the big problem, the one you're most likely to see walk through the door of the ER or your clinic. So here it is, the big question. A patient comes in with a fever, a swollen limb, and they're in a ton of pain. Is it the bone or is it the joint? The answer you land on here is a huge deal. It kicks off a whole chain of decisions, and getting it wrong can lead to permanent disability. So let's figure out how to nail this diagnosis every single time.
All right, let's jump into our first condition. We're going to start with infections that begin right inside the bone itself, and that, of course, is osteomyelitis.
Okay, so at its most basic level, osteomyelitis is just an infection of the bone, right? An inflammatory process. But that simple definition doesn't really tell the whole story. To really get a handle on this, you've got to think like a detective. How did it get there? How long has it been there? Where is it located? Because classifying it is the key to figuring out the right plan of attack. Think of this table as your field guide to osteo. You've got three main ways this can happen. First, acute hematogenous. That's when the bug travels through the bloodstream, kind of like a silent invader. Then there's exogenous, which is a direct contamination, maybe from an open fracture or even surgery. And what happens if you don't stamp out that acute infection? Well, it can turn chronic, just a smoldering fire waiting to flare up again. So let's paint a picture of acute hematogenous osteomyelitis. You've got a patient, often a kid, who comes in with a sudden fever, chills, and just terrible localized pain. And here's the key clinical clue. The pain is right over the bone. When you press on that spot, they practically go through the roof. It's not joint pain, it's bone pain. You'll also see the classic signs of infection, swelling, redness, and their labs will be screaming inflammation with high white counts, ESR, and CRP. And the usual suspect? Good old Staph aureus. Now here is a classic pitfall. Please don't fall for this one. You suspect acute osteo, you order an x-ray, and it comes back clean. It looks totally normal. It is so tempting to rule out the diagnosis, right? Wrong. In the early stages, we're talking the first week or two, the x-ray will be negative. The bone changes just haven't had time to show up yet, so you have to trust your clinical exam. The x-ray at this point can be really misleading. This is probably the single most important rule when you're dealing with these infections. Get a sample before you start antibiotics. I can't stress this enough. You have to know what you're fighting. Just throwing broad-spectrum antibiotics at it is like firing a shotgun in the dark. Sure, you might get lucky, but you're more likely to miss or just contribute to resistance. You need a targeted approach. Get that aspiration, get that tissue biopsy, and identify the culprit. That's how you win.
Okay, so what happens when this thing becomes chronic? Well, the infection creates this fortress for itself. It's called a sequestrum. And what it is a piece of dead bone that's been walled off from the body's blood supply. Think about that. Your IV antibiotics, they can't get there. Your immune cells, they can't get there. It's just a haven for bacteria, a little island of infection that's ready to cause a flare-up at any time. This is the hallmark of chronic osteomyelitis.
All right, let's switch gears and talk about septic arthritis. We're moving from an infection in the bone to an infection in the joint. And I want to be really clear here. This isn't just serious. This is a true orthopedic emergency. We are on the clock and every single hour matters. So why is it such an emergency? Why the massive rush? Because that articular cartilage, the smooth, gliding surface of the joint, is incredibly vulnerable. The bacteria, along with our own body's inflammatory response, create this toxic soup of enzymes inside the joint that just eats away at the cartilage. It can be destroyed in as little as 24 to 48 hours. And let me tell you, once that cartilage is gone, it does not come back. It's gone forever. So, how can you tell this apart from osteo on your exam? Well, here is the absolute key finding: severe, marked pain on passive movement of the joint. You try to gently bend their knee or rotate their hip, and they will scream. Any movement is excruciating. They'll hold the joint in what we call an antalgic position, usually slightly flexed. because that's the position of maximum joint space and it relieves the pressure just a little bit. That's a huge red flag for septic arthritis.
If you suspect septic arthritis, the next step is to aspirate the joint, and there's one number from that synovial fluid that should immediately set off alarm bells: a white blood cell count over 50,000. Just to put that in perspective, a normal joint has maybe a couple hundred white cells. 50,000? That is not inflammation, that is pus. It's a massive raging infection, and it means you need to move and move fast.
And here's a side-by-side that really drives it home. Look at the difference. On the one hand, a normal joint, very few leukocytes. On the other, septic arthritis, over 50,000, and it's mostly neutrophils. But look at the glucose. It's low, way lower than the serum level. Why? Well, because the bacteria are in there having a feast. They're consuming all the glucose in the fluid. So low glucose plus a high white count, that's a classic signature of septic arthritis.
Okay, so we've covered osteomyelitis and we've covered septic arthritis. Now let's put them right next to each other and really lock in the key differences so you can tell them apart.
All right, this is the money slide, your diagnostic showdown. If you remember nothing else, remember this. For osteomyelitis, the key symptom is pain when you press on the bone. For septic arthritis, it's pain when you move the joint. For osteo, your definitive sample is from a bone biopsy. For septic arthritis, it's from the joint aspiration. And for imaging, the classic sign of chronic osteo is that sequestrum, while in early septic arthritis, you might just see some joint space widening. Nail these 3 points, and you will be on the right track.
So once you've made the diagnosis, what's the game plan? Well, the goals are actually pretty straightforward. First, you have to eradicate the infection. Second, you have to preserve the function of the limb. And that means getting rid of the bad stuff and stabilizing what's left. Treatment really rests on a few key pillars. First, of course, are antibiotics. You'll start with broad-spectrum IV, and then you'll tailor them once you get your culture results back. But antibiotics alone are not enough. You also need drainage to get the pus out and debridement. That's the surgical removal of all the dead and infected tissue. And finally, you have to stabilize the area, whether it's with a cast, a brace, or even an external fixator. All of these have to work together. When it comes to the surgical side of things, especially for chronic osteo, you have to be aggressive. This isn't a time for half measures. The protocol is clear. Step 1 is a radical debridement. You cut away all the infected tissue until you see healthy, bleeding bone. If there's a seclestrum or a fistula, that's got to come out too. Then you stabilize everything. And finally, you have to deal with the empty space you've just created.
So, about that dead space. After you've cleaned everything out, you're left with a cavity. You can't just leave it empty. If you do, it will just fill up with the hematoma, which is the perfect breeding ground for bacteria to come right back. So you have to manage that dead space. You can fill it with antibiotic-impregnated beads, use bone grafts, or even set up a suction irrigation system. The point is, you have to do something to obliterate that space.
So let's end with this question, which really gets to the heart of the matter. What's the biggest risk if you delay the diagnosis? Well, it's permanent, irreversible damage. In septic arthritis, it's the destruction of the joint. In osteomyelitis, it's a chronic recurring infection that may never go away. In both cases, the result is a massive loss of function. So the stakes couldn't be higher. Getting this right, and getting it right quickly, can literally change the course of a patient's life.